Welcome everyone to the OLLI Medical Series. Tonight we'll be talking about metabolic syndrome. Metabolic syndrome is a preventable constellation of obesity, elevated cholesterol, and blood pressure, impacting all organ systems. It's the ultimate silent killer. The lecture tonight will give us insight into the condition and inspire you to focus on prevention and disease optimization that are directly within your control. Tonight, Dr. Victoria Lee will be giving our presentation. She received both her Bachelor's of Art and Bachelor's of Science degrees from Cal State University, Fullerton, and her Doctor of Osteopathic Medicine degree from Western University of Health Sciences and College of Osteopathic Medicine of the Pacific. With a background in teaching, nutrition, advertising, and molecular biology, she is uniquely positioned to educate and treat her patients' concerns and/or conditions. She has a passion for healthy living during all stages of life, with a special interest in geriatrics. Her main objective is to keep her patients healthy by encouraging positive lifestyle choices and being an advocate for their own health. Dr. Lee is currently an internist at St. Joseph's Heritage Medical Group in Tustin. Dr. Lee, would you like to go ahead?
Thank you so much, Bill, and thank you so much, Carol, for inviting me to this wonderful lecture series. So I am very excited to share this with you today. Is my volume good?
Yes, it is.
Perfect. So I'll go ahead and share my screen at this time. One moment. Sorry for the delay. Okay, here we go. Can you see my screen okay?
Yes, we can.
Wonderful. Perfect. So thank you for sharing your dinner time with me. I really do appreciate you being here, and hopefully you will leave, like Bill said, with a little bit more of pep in your step and plans to improve at least one aspect of your life tomorrow. So metabolic syndrome is a very, very large topic. Hopefully we will do a quick flyover of the definition and delve into actionable steps going forward. So please share your questions. And like we said, we will stop in the middle and at the end. So one of the things that I really have enjoyed about delving into metabolic syndrome is that with my molecular biology past and my research that I did at City of Hope and also Cal State Fullerton, I focused a lot on inflammatory factors driving cancerous growth. And so we will combine all of that along with the basic medicine concepts today for you. So get out your notepad and away we go. No disclosures at this time. So ultimately, after empowering you with information, I would love it if you would book an appointment with your PCP in order to chat about anything that doesn't make sense, in order to review any action plans that you may have had for your medication, to review any family history that suddenly popped into the front of your mind that you feel would be relevant to share with your provider. So try to jot those things down as well, in addition to any juicy morsels that you may find during this lecture. So this is actually a wonderful day to have this lecture. So 98 years ago, to the day, a published paper was released in Sweden by a physician that was trying to cobble together a constellation of diseases that he was thinking was similar in a metabolic breakdown. So Swedish physician Eskil Kylin, hopefully I'm doing justice by his name, I actually managed to get a copy of that paper. So today is very appropriate. Ever since then, for 98 years, we have been trying to cobble together conditions that are related in system breakdown, on inflammation, on increasing the risk for heart attack and stroke. 1988 was the next major stop, where Dr. Gerald Reaven actually proposed that insulin resistance also played a part in this constellation of hypertension. And, for some definitions, there's gout. And then ultimately, what we see is hyperglycemia or elevated glucose. And then Gerald Reaven also said that there was a noted increase in not only diabetes, which hyperglycemia creates, and also cardiovascular disease. So we are still working at it today. As you can see, this is from a major clinical resource for us. It's called a website called UpToDate. So this is a very nice snapshot of all of these 5 different overviews of metabolic syndrome. So after the World Health Organization in 1999 over here decided to cobble together their own version of risk factors, then we had the ACE, like diabetes guideline, International Diabetic Foundation in 2009, and then now we've combined it into the most agreeable constellation of components, which is the NCEP, which is the National Cholesterol Education Program, ATP, Adult Treatment Panel, 3 guidelines. And this is generally what we use going forward. But as you can see, from 98 years ago to today, there are still discussions on, well, should inflammatory markers be included? Should other factors be included? But right now, we're just going to focus on NCEP, ATP, or I will just say ATP guidelines going forward, just to make it a little shorter, where we're looking at the 5 components, of which you need 3 to get your definition of metabolic syndrome. So we will go ahead and review. So this is a little zoomed in. So we need 3 of the following 5 traits. Abdominal obesity, which if you get a tape measure out, waist circumference, or if you see WC going forward, that's what it will stand for, actually has different measurements for maximum ranges in men and women. And just as an aside, one of the things that I thought was actually very forward-thinking by the IDA guidelines was that they wanted to do ethnic-specific waist circumferences because some populations, some cultures tend to be a little bit more petite and others tend to be a little larger. The second point over here is the elevated serum triglycerides, right? So when you pull out that cholesterol panel that all your docs have been wanting you to get, that triglyceride is actually very, very important. Above 150 is a risk factor. Now, if you've had that 150 and you're on a medication for your cholesterol and your cholesterol looks normal, but you are on that medication, you still are checking that box for that elevated serum triglycerides. The next one, third point down, is serum high density lipoprotein, or HDL. Everyone knows this as the good cholesterol, and it's less than 40 in men and less than 50 in women. That is actually a risk factor. And so yes, if your good cholesterol is too low, that is not good. Or much like for the triglycerides, if you are on a medicine to treat your low HDL, that makes you check that box as well as a risk factor. Fourth point going down, your blood pressure. Now, there have been multiple different guidelines for blood pressure. The ATP3 guidelines say if your blood pressure is above 130/80, or you are on a medicine for treatment, you check that box. And then, of course, when we go down to the fasting plasma glucose, if you have a normal complete metabolic panel, or CMP, or basic metabolic panel, BMP, and that glucose, when you've not had anything to eat or drink, well, aside from water, for 8 hours, you get that blood test. If that glucose is above 100, then you get to check that box for a fasting plasma glucose abnormality. And then a little bit of things at the end that says the oral glucose tolerance test is recommended for patients, but not required. That is just a little peek into all of the things that we see going on behind the scenes. Well, should we modify the criteria a little bit? So needless to say, summary of the slide is this is your basic guidelines. A lot of them are still up for discussion in terms of nuances. So how widespread is this disease? So if we have a look at the data from 1999 through 2002, If we use the IDF guidelines, about 34.5% of the population in the US would meet the risk factors or criteria for metabolic syndrome, as opposed to if we use the ATP3 guidelines, we're going up to about 39%. So that's pretty impressive. And if you look back at the obesity rates, it's doubled in the past 3 decades. And of course, with the obesity, that is one of the factors, right? When we have the enlarged abdominal area as well. So think about that. That really does compound. 50% of the diabetic burden and 25% of the heart disease burden is actually related to being overweight or obese. And we know that metabolic syndrome is a precursor to that full-blown diabetic state and the development or percolation of that heart disease. So ultimately, when we look down at the Framingham Offspring study, let's just say we check in with patients 50 years older. Men, you see about 21% risk factor. Women, 12.5. And at 8-year follow-up, you will see it increases by 50%. So when we look at 65 plus population, that data is actually concordant with the 1999 to 2002 data in the first point, where your risk factor for having that in the population is about 35%. So a third to a fourth of you should be good in trying to create some actionable steps going forward here. So as we mentioned that on previous slides, we have multiple conditions. And it's not just one of the conditions, it's minimum of 3 of the conditions that substantiates this definition for metabolic syndrome. And unlike compounding of your bank account, this is not good. This is bad compounding, because when these conditions present together, the chances for your future cardiovascular disease is greater than just having one factor alone. In fact, it doubles the risk of cardiovascular disease, heart attacks over the next 5 to 10 years. And it increases the risk of you developing full-blown diabetes by at least 5-fold. So this is my happy place right here. It's kind of like the overview where we see in the top over here, we see the adipose tissue, right, which is the abdominal adiposity. We have the liver that's responsible for glucose regulation as well, along with your pancreas over here. And then we have the blood vessels. So what we're going to do is we're going to go through each one of those 5 risk factors, and we're going to pick apart this little picture, and then we will revisit this picture again. So don't worry about memorizing it all now. You won't be tested. It's okay. You're just taking notes, remember. Okay, so insulin resistance. There are 2 types of insulin resistance. There is acquired insulin resistance and genetic insulin resistance. So acquired is if you have a little bit more of that fatty tissue. As we age, we tend to not be as great with our insulin resistance. If we're not as active, if we have poor nutrition, if we're on a lot of steroids, so say you have an asthma patient that really is having a hard time year after year after year and we're giving them steroids, that is a risk factor. If you're on psychiatric medication, usually the schizophrenic agents, that can actually create a risk factor for insulin insensitivity. And then also HIV meds as well. If you have too much fatty tissue, like we mentioned in the first part of this table, and then if you have excessive glucose in your diet. So flip side of the chart, under the genetics, we have PCOS, which is actually a very common condition that usually presents in women of childbearing age having issues with their menstruation. So irregular periods, we oftentimes see an excessive male hormones in that. And then we have all of these very not that common conditions. So some Werner's, lipodystrophy, Alström's, and then myotonic dystrophy. So just know that you may have been dealt a genetic card that may be a little challenging, but that's only one of your risk factors. So we will still be able to help you. It's just the first part is education and awareness. Okay. So when we look at insulin resistance, the reason why we use the word resistance, is because your cells are not allowed to get that message from the insulin to say, hey, you just ate a massive meal. There's food in your stomach. We're breaking it down into sugar for you. The insulin is trying to get the sugar into the cell. What I like to do as a comparison for my patients is to say, okay, well, you went to a few too many rock concerts and you stood next to the speakers and you had something yelling in your ear, right? So you're eventually going to get a little deaf. I'm sure a couple people can attest to this. I have definitely done that myself. And so this is very similar to the insulin. So if you have very high glucose foods or medications inducing high glucose states, it yells at your cells at the volume of a rock concert. And then all of a sudden the sound disappears. So over time, your cells start to get a little deaf. So it's not just, your liver cells or any sort of specific cells. It's you have multiple sites that insulin interacts with. So you have the fatty tissue, the adipose tissue, you have the muscle tissue, and you have the liver tissue. So if we actually have a look and we kind of dive down into what happens with this fatty tissue, usually if you haven't eaten, you can actually break down your fatty stores into energy in the form of free fatty acids. Now, those free fatty acids should actually stop the generation process if your body senses that you actually ate food and you're intaking energy. So your body does not need to use its generation. That should turn off. So what happens is that you have not only the ingested energy through your food, but you have the made energy at the site of the adipose. This also happens at the site of the muscle. So if you ever have done a heavy workout, you know that your muscles just suck down all that glucose, right? 70% of the glucose that you get through your diet goes into those muscle tissues. So just think about that. 70% of the glucose coming in and your muscle is trying to still make its own power, trying to generate its own power. So then you actually have deposition into the muscle tissue, around the muscle tissue. And this creates a lot of inflammatory markers. The same thing happens in the liver. And I'm sure you have heard of the term fatty liver, right? Where the fatty tissue just gets deposited into the liver cells. And it can ultimately create a non-functional liver and cirrhosis. That's end stage. But this is why metabolic syndrome is such a beautiful thing to understand and try to prevent at this time. So when we're talking about excessive fatty tissue, right, a lot of the jargon that gets thrown around with obesity is actually defined by a BMI or body mass index range. So I'm not the biggest fan of BMI because it basically is a ratio of height to weight. I actually prefer muscle percentage and body composition. But because the BMI is used widely, we will just go ahead and review this. I get a lot of questions from my patients that says, okay, well, doc, from my height, what should I weigh? There are a lot of charts out there, so you can always have a look height to weight. But if you have a look at, the Rock, Dwayne Johnson, he's very, very muscly, and he would technically be in the obese category because he's very heavy for his height, but a lot of it is muscle mass. So if we have a look at your average body composition, where you have an excess of fat, not that much muscle, and you fit into these body mass index kind of areas where the BMI is 30 to or plus 30 plus, right? Because we have obesity, severe obesity, and morbid obesity. This is what we worry about. We do want to get that weight down into the overweight is better, but the normal BMI would be the best. Or if you are really just a super muscly person, then try to get your body fat percentage down. And now there are percentage recommendations for age and for gender. And you can look up tables about that. But I just wanted to do a deep dive into the BMI so it at least made a little sense to you. So when we're looking at abdominal obesity, not all fat is made equally. So as you see in my picture over here on the right-hand side, you see right by the intestines, you see this little fatty layer that's hugging the intestines. This is visceral fat. Then you have your abdominal muscle going out to the skin, and then you have your subcutaneous fat. The fat that we really worry about is the fat that's hugging your organs, because this actually has an expression and acts like an endocrine organ. It spews out inflammatory markers like interleukin-6, TNF-alpha, and it just upregulates all of that inflammatory cascade in your body, and that just goes throughout all the tissues. So a lot of people do have the subcutaneous fat, but it's this guy, the visceral fat, that we really need to look at. So what happens is we have higher insulin resistance, we have smaller LDL particles, right? And we have increased numbers of them. So they're smaller, but more volume in terms of the number of them. Hopefully that makes sense. So there's a change in the distribution of these cholesterol molecules. And then the VLDL, which is calculated in the non-HDLs, actually goes up. So if you're looking at your cholesterol panel, we have all of these remnants in the non-HDL. And then you can actually have the way that your body distributes your fat and ultimately your cholesterol can be genetics, can be just how your genetics change with regards to the interaction with your diet and environment. So this is a very big push and encouragement to say, even if you got a bum deck of cards that you know, with your genes, you can still change them. You can still change them. This is awareness. So when we're looking at the cholesterol, talking about getting bad cholesterol genes, when we're looking at fatty foods, let's just say you eat a burger, okay? The fatty acids are absorbed and put in these little bubbles called chylomicrons. And then they, of course, go into the muscle and then the fat. And then they go into the liver, and the liver tries to change the types of fatty molecules. And basically, we get a lot of free fatty acids. Free fatty acids, when combined with a backbone in a number of 3, actually are triglycerides. So that leads us to kind of go back and say, okay, my food, the stuff that I choose to eat, can play an effect into inflammation, free fatty acid, and ultimately impacting the insulin sensitivity in a way, right? And then once we have all of this inflammation with these free fatty acids, if we ate a nice burger, we actually worry about something called atherogenic cholesterol or atherogenic dyslipidemia. And that is the inflammatory cholesterol, which is the LDL-C, which is the triglycerides. Triglycerides, once again, come from free fatty acids, right? So if we actually look at how the artery wall is damaged, this is a really cool photo. So what we see on the left is a pretty decent, pretty good looking artery, if I didn't say so myself. We have initially an inflammatory response that damages that non-stick, kind of like Teflon inner lining of your vessels, right? Because things shouldn't stick to it. When we pop out of the womb and we're babies, our blood vessels are like a non-stick frying pan. Over time, they get a little bit of scrapes, a little bit of bumps, a little bit of turbulence from that blood pressure. We start to damage that non-stick layer, and underneath is a very, very sticky bottom layer. And then you start to get these atherogenic cholesterols stick on in there. And we get a fatty streak, which is how it starts. And then it starts to build up, and then we get an atheroma, and then you get fibrosis, and then you get a rupture. Now, if the rupture is in your heart, that is a heart attack. If the rupture is in, your brain, then that's a stroke. then that is ultimately why we are wanting to treat this metabolic syndrome. So if we have a look down at the bottom, this is actually from a really nice website from, I believe it was Australia or New Zealand, pardon me. We have on the top of the slide, it's actually a healthy population over here. And then below it, it's a heterozygote where you have, one bum gene, and then you have homozygote where you have 2 bum genes of cholesterol, right? So as you can see, starting around your 4th decade, if you have really good genes, but really bad inflammation, diet, exercise, you have predisposition to insulin issues, or you're on some medications, right? You're going to start to develop these foam cells and these fatty streaks. And in your 6th decade, you're going to be in the mid of the picture, right? And then around your eighth decade, you're going to get really, really high risk if we don't change anything of heart attack and stroke. And if you get 1 bum gene, you're going to start to develop by the time you're in your 3rd decade, you're like, 30 years ahead building your plaque in your vessels compared to some healthy person. And then if you really have bad genes within the 1st decade, you are just building everything up. So on to blood pressure. Now that you have the bad vessels with a lot of the plaque in it, we really want to make sure that we take a look into the blood pressure, right? Because think about pipes of your house. If you've got a lot of calcium buildup, right? You're going to get calcium flying everywhere if the pressure is too crazy. So blood pressure, 54% of the strokes and 47% of the coronary heart disease worldwide are attributable to high blood pressure. So that means for 50%, we can actually help. Blood pressure that's elevated is one of the most important risk factors for cardiovascular disease, which is the leading cause of mortality. And then stroke remains the 2nd most common cause of mortality over the last 3 decades. So this, I thought, was very, very mind-opening. When we looked at the prospective study collaboration, we showed that patients that were 40 to 89 years of age with blood pressure, right? For every increase in 20 millimeters of mercury systolic, which is the top blood pressure number, the highest pressure that you get when your heart pumps, and every 10 millimeter of mercury, which is the bottom number, was associated with doubling the risk of stroke. So we will get back to how you can fix that in a little bit. But that's a very sobering number. So we do see a doubling effect just with 20 over 10 additional points. So like I promised, we are back to our review from the top, and I apologize if I've lost you in the weeds, going a little bit too deep, but here is our little picture to pull it back together. So when you eat your burger, right, if you have insulin insensitivity, your body is in power generating mode. You have lipolysis, which is where your body is generating free fatty acids, which is their form of energy in the fat cells. We are generating energy in the muscle. We are generating energy in the liver, right? So these are the top 3 things. And then when you eat, if you have insulin insensitivity, right, remember how it makes the fatty tissue more inflamed. It makes the liver more inflamed, ultimately getting fatty liver or hepatic. Hepatic means liver. Steatosis is fatty, right? And then in the muscle, we have these fatty deposits around here with very poor glucose utilization. FFA over here is the free fatty acids, okay? And then over in the middle is your TNF alpha and your IL-6. Those are your very inflammatory proteins that have been associated with upregulating certain cancers. CRP is C-reactive protein, which is also elevated over here. There have been some discussions as to, since, as you can see, the central component of metabolic syndrome does involve inflammatory markers, should we add CRP to the screening? There has not been a consensus, and the ATP3 guidelines do not have that inserted in there. And then going down, if your insulin is insensitive, Remember how you're standing next to that big speaker at your favorite rock concert? Eventually, as we get older, you're going to have your partner or your family members yelling at you, right? And they're going to lose their voice. So that's exactly what happens when we have insensitivity of the insulin. Your pancreas is yelling so much with those poor little beta cells that it actually cannot make any more insulin. So you can actually get pancreatic failure and then develop type 2 diabetes. And then down the bottom over here with this inflammation, we lose that nonstick Teflon inside of our blood vessels, right? We get a lot of atherogenic lipids, right? So they deposit in there. They create a film, much like calcium inside the pipes of your house. And then when we add blood pressure to all of this, we get high blood pressure when we have more abdominal weight, right? And then remember that 20 points of the systolic and 10 points of the diastolic will increase your stroke risk significantly. And that is metabolic syndrome, at least from ATP3 guidelines, in a nutshell. So, any questions?
So if you have any questions, you could type them into the chat or raise your Zoom hand, and I'll let you go ahead and ask your question. So we do have a question in the chat.
Okay.
As we get older, we tend to shrink a little bit over our lifetime.
Mm-hmm.
Does that mean we have to lose weight to stay within the norms for our new height on the BMI?
I love that question. I love that question. Okay, so the shrinking that you are referring to is actually more likely osteoporotic, so where your bones lose the height. So I actually have some patients that have lost quite a few inches, but generally if you look at the range of the BMI, let me actually go back to the BMI slide for you. It really isn't too much of a change. Generally, the change between overweight and obese is significant. So I think you're probably looking at maybe like a couple pounds less. And I would say that just from if you were my patient, I would say it's negligible, right? At that point in time, I would be counseling you about something else, about like, bone density.
Okay, Jody, go ahead.
Yeah, is there any effective way to know what the heck is going on in your arteries? I mean, how do you, I've been to a couple of those little health screening things, and they'll do an ultrasound or they'll do some sort of thing to see the status of your arteries. I do not know how effective or honest or true that is. Is there anything now or on the forefront so that we can see how much plaque is in our arteries and what damage it's doing?
Yes, absolutely. So thank you very much for your question. So back to the arteries. So when we look at arterial disease, and this could be a lecture in and of itself, we can evaluate the heart in terms of a calcium score, which is a CT scan of the heart that calculates the in a numerical range how much calcium is deposited into your cardiac vessels. Sometimes if you do have carotid disease, which are the main arteries in your neck going from your heart up to your brain, you can actually do an ultrasound of that. The ultrasound is read by the radiologist in terms of percent of occlusion, so how much percent is closed. And there is a threshold for a surgery in order to help with that. And then in terms of the arteries in the legs, there is something called an ankle brachial index, which oftentimes is done in a lot of these healthy vascular screens, which looks at the difference in the blood pressure between the arms and the legs. And based on that ratio, we can actually see, are your vessels hardened? And that you can actually meet with a vascular provider that will do a CT scan with runoff to see if you have any specific clogs in the lower extremity as well. So hopefully, did I answer your question?
Yeah, she's muted, so
Okay, so in summation, there are 3 ways for your heart. That would be a coronary CT score with calcium scoring. For your legs, it would be an ankle brachial index to check for peripheral vascular disease. And for the carotid arteries, you can always do an ultrasound. If you have had any sort of knee x-rays or abdominal imaging or anything like that, sometimes the calcium does show up on those x-rays because calcium is like bone, it looks white. So oftentimes if I do catch that, I will show my patient that on their x-ray and say, hey, you know, we need to work on this, or order a follow-up study.
Okay, we have some more questions in the chat.
Mm-hmm.
So throughout most of my life, I've had low blood pressure.
Mm-hmm.
In the last year, my blood pressure is usually around 134. And at times, it goes up to as high as 159.
Mm-hmm.
What is causing this change? I'm 85 years old.
There you go. So there was a wonderful cardiologist that I had the privilege of having a lecture from about 2 years ago. And as we age, our blood vessels get less flexible. And so you do get a little bit more ups and a little bit more downs. There are a lot of factors going into blood pressure. So what I would do is try to make sure that you're taking your blood pressure in a consistent way every day. So as you know, make sure that you've used the bathroom. A full bladder will increase your blood pressure. Make sure you have your feet flat on the ground and you have relaxed for about 5 minutes. No caffeine or tobacco in your system within 30 minutes. And then you just relax and then take a blood pressure reading. If you do this consistently, you'll be able to see, is this just a timing issue? Is it when your blood pressure is running out? Or is this, you know, something that we really do need to address, because some people do have very labile blood pressure. So I would definitely check your blood pressure, write it on a log, and schedule an appointment with your PCP, because this is a little bit of a digging situation. We want to talk to you more about it.
Once your arteries have hardened, can that be reversed?
It depends how they harden. So for a carotid artery, I mean, you can take out the plaque. If you're having higher blood pressure because of the muscular layer that's thickened, generally you cannot really undo that unless you have some medications to specifically target that. So that is a complex question. I would recommend working with your PCP.
Okay. I don't see any other questions right now. So you continue on with your lecture.
Absolutely. I love the questions. Thank you, guys. Okay, so now it sounds like I've scared you quite a bit. So we will jump into, well, what can we do about this? Okay, there's a lot that you can do about this. Okay, so if you have identified with 1 out of the 5 risk factors, or multiple, or maybe even all of them, or maybe you're on medications for diabetes, blood pressure, cholesterol, and are a little bit more fluffy in the midsection, we can definitely make a plan. So in terms of the recommendations, these are very academic and textbook recommendations. Some people may not be able to meet these within the time frame, and that is okay. Then that means we need you to work with your PCP, consider a registered dietitian, registered dietitian consult on a one-to-one basis to try and help give you realistic ways to improve your risk factors. So for obesity, you can look at that BMI. What I would be very, very happy to see is if you kept your same body size, but you increased your muscle mass, right? Or you kept your same weight, you increased your muscle mass. So your clothes may fit better, but the scale may not change. And for the question for the person who was shrinking, that was concerned about adjusting the weight, I would definitely try to add in more weight-bearing activity, try and get those bones up and at them, try to improve that muscle to really maintain that bone density if we can. And then the weight will come down if the muscle goes up. So once again, we want to be in the BMI category of less than 25, okay, which is the normal range. 18 to 25 is the normal range. for that. And then once you have lost the weight, or if you want to go down 10, 15 pounds and then maintain, and then 10, 15 pounds maintain, the maintenance and not bouncing back, especially over the holidays, is very, very important. A physician that I took over my practice from, she was very, very graceful with herself, and she would say, you know what, I stopped weighing myself in November. If I still fit into my same pants by January, it was a good holiday. So sometimes we just need to give ourselves grace, but grace does not mean complacency. So put down that cupcake and try to, have something a little bit healthier there. We do want to make sure that you have physical activity, right? So once you've put down that hamburger, put down that cupcake, and then add a little bit more veggies into your diet, go and move, right? I know that this has been a very big challenge over the last year, where a lot of our normal activities have been very restricted. And so a lot of my patients have basically just sat at home. So what I encourage my patients to do, because sometimes that's also driven by anxiety and depression and the sense of being overwhelmed. If you're going out to get your mail, go for a walk around the block. You can break up your activity into 5 or 10 minute segments, 2 to 3 times a day. That still counts, right? Start small. Be very graceful with yourself. You've been through a lot. So try to grab your partner. If you are guilty of sitting and watching way too much TV during the daytime, after lunch, go and grab your partner and go for a walk. Make sure you wear some sunscreen and a hat. That would definitely brighten your mood. It will help your bones, and it will help your circulation. And remember, 70% of that glucose goes to your muscle. So you'll be using that glucose. And then once again, building that muscle that I referred to in the previous slide, we really do want to make sure that you do some form of resistance training about 2 days a week. And that's to maintain your muscle. You can do it 3 days a week if you want to try and build a little bit and work on that body composition that we discussed earlier. So the things that I like to do is some yoga, some of those, yoga courses actually do have quite a few squats. If you're doing chair yoga, sometimes you can do resistance bands. I love to do Pilates. It really does help the pelvic floor and even out the damage that excessive sitting does. So really try to look into things. And once again, a 10-minute Pilates routine paired with a 10-minute walk, you're better than you were yesterday. I guarantee you. So improving your cholesterol. Now this is where I really do want you to go and get your labs if you have not had a cholesterol panel in the last year. I want to see where you are, right? Your PCP wants to see where you are. We have done a lot of stress eating, and our cholesterol panels have definitely changed. There are specific guidelines for LDL goals that PCPs and cardiologists like to use in order to reduce your risk of heart attack and stroke. You may see that sometimes the goal is 70, 100, or 130. We do a lot of discussion and look into your risk factors. Statins are the preferred drug just because they have had such favorable outcome in preventing heart attack and stroke. So when we look at prevention, there are 2 terms that we're looking at. First is primary prevention, right? Which is where you've never had a heart attack and stroke, and we don't want you to get one. So we're treating you to prevent your first event. And then we have secondary prevention, which is you've had a heart attack and a stroke, and we're trying to prevent you from having another one. So depending on where you are, depending on what your body can handle, because I know some people don't tolerate statins very well, and that's fine. That's a discussion for you to have with your doc. There are other agents. We really need to focus on getting that cholesterol down so your arteries do not get that plaque in there. They do not start with their shenanigans and creating a risk factor for a heart attack and stroke if we can prevent it, if we get in there early. And then remember how the free fatty acids were combining with a backbone to create the triglycerides, and the fatty acids were creating the inflammation, right? So when we have the triglycerides elevated above 150, which I pointed out at the early slides of this lecture, that is actually something that we really do want to treat as well. So generally, if you do have triglycerides over 500, then we can put you on certain medication. I'm generally pretty aggressive with my patients' triglycerides if they go above 150 in terms of initiating lifestyle changes. You know, like I said, put down that cupcake, put down that hot dog, put down that, you know, whatever your happy food is, right? Or cut it in half, share it with a friend, or only eat it on a Sunday. We may need to do things on a daily basis or weekly basis that decrease that triglyceride so you don't get that inflammation on the back end, depositing in your liver, in your muscle, and in your fat further. And then your blood pressure. So like I said, that was a really very good question for that blood pressure. We want to make sure that you're actually checking your blood pressure accurately. Every blood pressure cuff may be a little bit special, a little bit off in some way. We want to make sure you have a good cuff size, you have a good blood pressure technique at home, and we want to make sure that we actually do check your blood pressure at home at least 3 to 4 times a week just to know where your normal is. If you do feel a little weird, if you have a headache, feel a little woozy, please check your blood pressure. And if you do have weird readings, there should be a nurse advice line attached to your primary care office. And you can always call them 24/7 if you have questions, if numbers don't look right. So we have a lot of blood pressure guidelines. The most recent, I believe, was the Sprint guidelines. You might have heard, JMC8 guidelines, and this is where we've had this kind of back and forth between, is it 130 over 80? Is it 140 over 90? There's been a lot of confusion, and it seems like every other year we're coming out with different guidelines. Bottom line is, in all of the guidelines that we see, the lower the blood pressure, the better, as long as you're not fainting, lightheaded, or lethargic. Okay, so that's why we usually like to keep you around 130 over 80. What I tell my patients is, for more than 50% of readings, we want you to be under 130 over 80, because much like the question in the middle of the lecture, you are going to have some elevations, right? You might have gone out and chased some, raccoon out of your yard, and you came back and you were a little upset, right? Sit down for like 5-10 minutes, relax, just be very, very calm, and then recheck your blood pressure. If your blood pressure is still elevated despite relaxation and being compliant with your medication, then we do need to intervene a little bit more. So ultimately, if you do have blood pressure that's like 120 to 130, we may just kind of say, hey, be aware of when you eat salt, right? Salt reduction is not the best thing, but I know that it does actually help. Try to eat a little bit more leafy greens and vegetables, which is the premise of the DASH diet, where vegetables actually does balance out your sodium and potassium transporters naturally. And so that's why normally with a plant-based diet, you will see your blood pressure come down. So exercise as well will work into getting that blood pressure down afterwards too. So, and once again, the insulin resistance. We do want to make sure that we're not having too much saturated fat. If you're going to have a turkey burger, put avocado on it. Don't put bacon on it. We want to try and avoid the simple sugars. You are sweet enough. I listened to all of the banter before the lecture. You guys are just an absolutely beautiful, wonderful group of people. So you are definitely sweet enough. You do not need sugar. You can have sugar for special occasions, but just make sure it's, 1 or 2 bites, because quite frankly, that's all we really taste. And then the rest, the bites after that are just kind of rote. And then, be aware of the fat intake. I know that there's people doing keto diet and whatnot. Keto diet is not the best for people with the genetic cholesterol abnormalities. So you have to really be aware of that before you go into a keto diet. A lot of the research is coming out of a Mediterranean diet. So I would say low glycemic, low inflammatory Mediterranean diet. Keep your eye on your plate. 50% of your plate should be veggies. I know that some people absolutely hate vegetables, then we may need to look at, making your own soups at home or blending something into a little smoothie. There are ways to sneak things into your diet. Half of your plate should be vegetables. It's a palm size protein, and then a fist size of your carbs that are hopefully going to be complex carbohydrates. You can always work with a registered dietitian. If you do have any bowel issues, any IBS, any kidney disease, we do want to make sure that we avoid certain foods and we monitor the potassium intake. If you do have stage 4, stage 5 kidney disease, we would want to be a little bit more aware of that. So working with a registered dietitian is always recommended to customize these approaches for you. And so everyone has a bit of control issues. So in summation, I know that I have chatted your ears off tonight, and thank you so much for staying with me through to the end. These are the things that I do want you to focus, right? So now we've done a flyover of metabolic syndrome, all the organs that it hits, and then we've gone over everything that you can do. So check your blood pressure at home. Write it down. If you have diabetes or impaired fasting glucose, check that at home. My favorite patients are the ones that bring me the blood pressure log when I see them. So I know it's, not elevated at home, the same way that it is when I see you in my office, because white coat high blood pressure is very real. If you check your glucose every day, then you should know what your baseline is in the morning. If you do start to get an infection, you will see that glucose rise a little bit. That's my sneaky takeaway. So know your baseline blood pressure, know your baseline glucose, and really, like I said, jump in to, once you have had your vaccine and you feel comfortable, go and get your yearly labs, your Medicare annual wellness, your physical, and really try to take a look, because now you know a little bit more about your cholesterol panel, about your glucose. And if you still have questions about your genetics, right, your family history, think about heart attack, stroke, cholesterol issues, diabetes issues. Those are the things that I would really want to know as a primary care physician, because I would keep a little bit more of a protective eye out for you. And just realize that giving ourselves grace, right, even if it is just a walk around the block or adding a side salad, you are doing a better job, right? This is additive. This is compounding. And so this is, in summation, this is the American Heart Association and Johns Hopkins, just to pull it into an academic snippet. So the one thing that I do want to emphasize is, please take your prescribed medications. If you do not know what they are for, please ask. We would love to tell you and review with you and optimize the time that you're taking them, in addition to encouraging you to improve your exercise and diet. Try to also limit alcohol. That's one thing I did not touch in, but that definitely can make a big difference in inflammation and sugar. So thank you so much for your kindness and your patience and for being with me tonight. Do you have any other questions?
Yes, if you have a question, you could type it into the chat or raise your Zoom hand, but we do have a couple of questions. Are there any warnings about artificial sweeteners?
So none that I have refreshed my memory on as of the last week preparing for this lecture. What I have been reading in the last, I would say, year, is that some artificial sweeteners can actually increase your desire for more sweet foods. So that is my main reason as to why I recommend my patients to stay away from artificial sweeteners, is because it creates like a rebound desire for sweet foods. But aside from that, I have not read anything recently that I can speak intelligently to.
Does metabolic syndrome affect cancer risk?
Yes, it does. So if you remember, I'll go back over here. Over here in the center of this molecular overview, there is TNF alpha, which is tumor necrosis factor alpha, and IL-6. So if you do some Googling and some research, I actually did breast cancer research at City of Hope and that was before medical school. And the project that I was directly related to was isolating IL-8, which is another inflammatory factor, and how that is actually upregulated by tumor necrosis factor alpha, so TNF alpha. So we know that if you have high levels of TNF alpha, you can have higher levels of other inflammatory cytokines. If you want to Google inflammatory cytokines, that can create a cascade where you're upregulating, different cancer genes. And so I do not know at this point in time the percentage of risk that it increases. I did not read that in my prep, but I know just from my previous personal lab research that the center of that metabolic syndrome with the inflammatory markers have been associated in the projects that I've been related to increased at least breast cancer risk that I know of.
How does alcohol affect metabolic syndrome, and what are reasonable guidelines?
So alcohol breaks down into sugar, right? And so sugar is the center of increasing insulin resistance. So guidelines vary. So if you have liver disease, of course, we do not want you having the alcohol. If you're on certain medications, pain medications like NSAIDs, alcohol can increase the risk of stomach irritation, and anxiety, depression medications that can increase complications as well. In terms of guidelines, I would work with your PCP because for some patients, I would say absolutely no alcohol based on what I see. And for other patients, I would say, moderate. 1 glass is okay. Try not to do it every night, but those recommendations should be made after we do a good look at your current health.
What do you think of CoQ10?
CoQ10 is good. It actually can be combined with statins. It does reduce the risk of statin-reduced muscle pain by about 10%. So 1 out of 10 patients have some relief with that. So yes, I absolutely do agree with it.
Okay, are there any other questions out there? I'm not seeing any. So we want to thank you, Dr. Lee, for being here tonight. This has been both scary, informative, and helpful. You've given us some steps that we can follow to help ourselves. So we want to thank you for being here tonight.
Well, thank you. Thank you so much, Bill and Carol. I really do appreciate your offer to host me, and thank you so much for everyone who listened.
Okay. Our next week's medical series lecture will be February 24th at 9 a.m. about hospice and palliative care. There is a change in doctors from the Blue Book. It'll be Dr. Brian Boyd will be presenting next week. Also, the Transitions in Retirement lecture this Saturday at 9:30 is Retiree Health, Social Trends, and Technologies. We'll see you next week. Thank you, everyone. Stay safe.
Thank you. Thank you, Debbie. And Bill and Carol.
Thank you. Good night.
Thank you. Thank you, Bill and Carol.
Bill, for all you're doing to facilitate this.
You're welcome.
So we leave.
Mhm.
Well, most people are gone now.
Thank you again, Dr. Lee.